Hi everyone, this is Melissa Shigoda from NNPHI, and I'm happy to welcome you to the first in our series of Community Health Improvement Capacity Building webinars. This webinar is called Rapid Community Health Assessment, a Gulf Coast Case Study, and will feature Dr. Samantha Francois from the Louisiana Public Health Institute. We're so glad you could join us today for this exciting opportunity. Before we get into the presentation, I'd like to take a few minutes to provide some background on the series and introduce today's presenter. This webinar series grew out of the work of the capacity building subgroup of the Community Health Improvement Work Group that started meeting this past fall. And if you aren't already a member of the work group and would like more information, please contact me via email at mschigoda@nnphi.org, and I'll enter that into the chat box right now so y'all have my email address. And the purpose of this webinar series is to provide an opportunity for NNPHI member institutes to learn from their fellow institutes about how they've selected and adapted specific tools and processes for their community health improvement initiatives. On today's webinar, Dr. Francois will share about the rapid community health assessment process used across a 4-state region along the Gulf Coast impacted by the 2010 oil spill. She'll also share how LPHI collaborated with the Florida and Mississippi Public Health Institutes to support ongoing community health improvement efforts with their local health departments. Throughout this presentation, we'll stop several times to ask for questions and comments from participants. And at that point, I'll unmute the line so people can ask their questions themselves. But if we have any problems with feedback or background noise, I'll just leave the lines muted, and you can enter your questions into the chat box. And then we'll also have time at the end for final questions and discussion. So before we get started, I'd like to introduce Dr. Samantha Francois, the Associate Director of Program Evaluation and Assessment at the Louisiana Public Health Institute. Dr. Francois oversees the assessment and evaluation of the Gulf Region Health Outreach Program's Primary Care Capacity Project and the School Health Connection programs. In this capacity, Dr. Francois leads the design and implementation of community health needs assessments, school health needs assessments, health center assessments, as well as individual and community level program evaluations. Later on in the call, we'll also be joined by Dr. Roderick King, Executive Director of the Florida Public Health Institute, who will be able to offer perspective and insight into the LPHI-FLPHI joint work with the Florida County Health Departments. Dr. King is currently faculty in the Department of Global Health and Social Medicine at Harvard Medical School, senior faculty at Mass General Hospital Disparities Solutions, and a Fulbright Regional Network for Applied Research Nexus Scholar. His academic work and teaching and key consulting roles focus on improving the health of underserved communities via leadership in organizational development and human capital development. In particular, Dr. King has worked to improve the health of communities nationally and internationally via training and facilitating collaborative leadership efforts to support leaders in creating aligned actions and measurable results for underserved communities. And with that, I'd like to go ahead and turn it over to Samantha. Samantha, if you want to just go ahead and unmute yourself. Let me try.
Okay, I think that works. I couldn't put myself in the list. Sorry. Thank you, Melissa.
Yep.
Good afternoon, everyone. Thank you for taking out the time this afternoon to join us for today's webinar. Today I will describe a rapid community health assessment process the staff here at the Louisiana Public Health Institute developed in order to identify health priorities in 17 parishes and counties along the coast of the Gulf of Mexico. And this assessment process was developed and implemented in order to inform funding and resource allocation decision-making for community health centers in the communities in those 17 parishes and counties, and also to activate and support ongoing community assessment and improvement planning efforts in those communities. Historically, Gulf Coast residents face healthcare challenges that are both severe and specific to the particular geography, demography, and economy of the region. In recent years, vulnerability of this region to both natural and man-made disasters has exposed the lack of an adequate healthcare infrastructure. As one might imagine, these challenges were exacerbated following the hurricanes over the last decade, as well as the recent Deepwater Horizon oil spill in 2010. And many of these limitations or challenges to the healthcare infrastructure have still yet to be fully addressed. So given that, we will focus on the Gulf Region Health Outreach Program, which is part of the Deepwater Horizon Medical Benefits Class Action Settlement, which was administered by the Federal District Court for the Eastern District of Louisiana. So what is the Gulf Region Health Outreach Program, or GRHOP, and how does it fit with regard to community health assessment work? The Gulf Region Health Outreach Program, or GRHOP, was developed in response to the 2010 oil spill. GRHOP is a series of 4 integrated 5-year projects designed to strengthen health care in Gulf Coast communities in Louisiana, Mississippi, Alabama, and the Florida Panhandle. The GRHOP was developed jointly by BP and counsel representing certain plaintiffs in the Deepwater Horizon litigation in the U.S. District Court in New Orleans. The target beneficiaries of GRHOP are residents, especially the uninsured and medically underserved of 17 coastal counties and parishes in those 4 states. In brief, there are 4 projects that make up GRHOP, and they are the Primary Care Capacity Project, the Mental and Behavioral Health Capacity Project, the Environmental Health Capacity and Literacy Project, and the Community Health Workers Training Project. The Louisiana Public Health Institute administers the Primary Care Capacity Project, or PCCP. The goal of PCCP is to collaborate with the other GRHOP projects in each state to increase access to integrated primary care with linkages to mental, behavioral, environmental, and occupational health care for residents in areas that are vulnerable to the impact of both man-made and natural disasters. This is a large charge, but our approach to the first year of the project was to start this effort by conducting a comprehensive regional community health assessment alongside our other GRHOP partners. This included assessing the capacity and operations of community health centers in the GRHOP footprint, but it also heavily relied on a rapid community health needs assessment in each of the 4 states, in combination with the health center assessment. The regional assessment was intended to identify relevant health and quality of life data in order to characterize sub-county health disparities, catalog community assets, inform priority setting, and help inform programmatic decisions around investments and inputs into both community health centers as well as community health improvement planning in those counties and parishes. The rapid nature of the assessment was due to the court mandate to disseminate funding into these communities before the end of the first year of the program. So this slide is to show the footprint for the GRHOP program as well as the Primary Care Capacity Project. So there were the parishes in Louisiana and then the coastal counties in Mississippi, Alabama, and Florida. In general, the assessment process designed to inform the first-year funding investment in the community health centers was clear. However, there was one challenge that we as the Louisiana Public Health Institute could not overlook. We were the Louisiana Public Health Institute, and although one of the states in the GRHOP footprint was Louisiana, the other three were not. Therefore, we embarked upon a rapid community health assessment process in Mississippi, Alabama, and Florida within the first year of the program in order to fulfill the settlement mandate to disseminate funds to those communities prior to the end of the first year of funding. I will also note here that 2 communities in Louisiana were specifically named in the settlement, so there wasn't as strong a need to conduct the rapid assessment process for Louisiana. So among the objectives of the Primary Care Capacity Project, or PCCP, was to conduct a comprehensive regional assessment of community health needs to inform priority setting, policy making, asset cataloging, health strategy development, and determine a baseline for setting community health objectives and measuring change over time. Thus, the rapid community health assessment allowed us to get a baseline of community health status, healthcare needs and assets, and barriers to care. The rapid assessment approach was a mixed method one and consisted of 2 components, a review of existing quantitative data, and also a facilitated key informant prioritization process to gather qualitative data. The existing quantitative data review included a review of state, county, and sub-county level data to characterize demographic, health, and quality of life factors. The qualitative community prioritization process was meetings held with key informants representing the eligible counties in Alabama, Mississippi, and Florida in order to collect information from community stakeholders to validate and prioritize findings from the quantitative data review. In the webinar, I will highlight the 4 major steps behind this rapid mixed methods community health assessment approach that was adapted by the Louisiana Public Health Institute specifically for this multi-stakeholder, multi-partner, multi-state program. And I'll also note that many aspects of the process, of the approach, was borrowed from and modified aspects of MAP's community health status and community themes and strengths assessments. So the first step in our rapid process was to identify and coordinate stakeholders in these communities working with GRHOP partners in each of those states of Mississippi, Alabama, and Florida. I'll quickly review each of the 4 steps, and then I'll go into greater depth with each of the steps. The second step was to identify the relevant health and quality of life data in order to characterize health disparities, catalog community assets, and inform the priority setting and programmatic decision making. The third step in our process was to develop a guided prioritization process in which we considered how stakeholders would consume existing quantitative data on their communities, what data was actually additionally needed from stakeholders, and then how to bring together data from both sources. The final step involves, all 3 of the previous steps. Combining all information gathered from the 3 previous steps so that stakeholders could vote on and identify specific health priorities for their communities. So one main objective of the process was to have local key informants identify the top health priorities in their counties. These priorities were then considered alongside findings from the health center assessments that were happening simultaneous to this assessment process, to the community assessment process, in order to inform funding and resource investments to the community health centers and in those Gulf Coast communities. So I'll pause here to open it up for any questions at this point in the presentation. The next section, I will go into greater detail for each of the steps I just quickly identified. but I do want to pause here to see if anyone has questions at this point. Melissa, can you unmute just to see if anyone?
Yep,
The conference has been unmuted.
Okay, great. Now everyone is unmuted. Are there any questions, comments at this point? Okay, so we'll move along. Thank you, Melissa.
Okay, I'm going to go ahead and mute everyone again.
The conference has been muted.
Communities in Mississippi, Florida, and Alabama. So determining who should be at the table. Using guidance from MAPS as well as the Catholic Health Association's recommendations for participants to get community involvement and input, we developed a list of key informants to participate in the assessment process. We came up with a list of organization types representing health, education, government, social services, as well as community residents to ensure we had representation from multiple sectors within each target community. We then worked with our GRHOP partners in each state to identify agencies within each of these sectors to contact for participation in the community assessment process. This step then led to a type of snowball sampling method where we would make contacts with an agency and they would recommend other agencies or organizations or individuals who are also community stakeholders that should participate in the assessment. Through this process, once we arrived at a list of agencies and participants, this list was then again reviewed with the GRHOP partners to ensure we had the right people at the table and that no key stakeholders had been left out. So I'll open it up again here for some discussion around the questions we were grappling with when we were going through this process of identifying stakeholders. So questions we were asking ourselves is, who is missing from the list? What issues do we need to consider when speaking with these stakeholders coming from an outside organization based in another state? What will be some of the responses we can anticipate, and what should be expected of the stakeholders once we gather them around these issues? So I'll ask Melissa to unmute the phones again and open it up for a little bit of discussion. If people have any other questions around our process for coming up with a list of stakeholders to include in this rapid assessment process.
The conference has been unmuted.
So does anyone have any questions or thoughts or comments around the process as I described it?
Hey, Samantha, this is Jennifer. I have a question about just how and kind of where in this process were you able to ask yourself kind of what are the other health assessment activities that might be going on in the area, and being able to connect with them?
That's a very good question. Thank you for that, Jennifer. And that was something we actually did from the very beginning of the process, because we realized that, you know, there could already be and likely were already assessment processes happening. So, for example, we knew in Louisiana, because we had been involved in both here in New Orleans in our city health department's assessment process. We were involved in the state health department's process. So one important starting point for us when engaging stakeholders, we're starting with the local health departments and learning about, you know, what assessment or community assessment processes had already happened or were already happening in those communities, both either led by the health departments themselves or if nonprofit hospitals had conducted or were conducting assessments in those communities. So we actually were having those conversations as well when we were engaging with stakeholders. And in those instances where we did learn about assessments that had already been done or were ongoing, we tried to link with those stakeholders to either get their final assessment reports so that we weren't duplicating efforts or that we were complementing what had already been done. And I can give Florida is actually a very good example of this, and I don't know if Dr. King has joined the call yet because he can certainly speak to it as well. But when we started our process, we learned that the 5 counties in Florida that were a part of the GRHOP footprint, all of the county health departments in those 5 counties were at different phases of their own assessment process in pursuit of accreditation. So we linked with those county health departments to learn about where they were in their process, to get any published reports that they already had, so that we could even use the data that they'd already gathered from their assessment process in our own assessment processes. So that was a huge part of our process, not just in the sort of planning phase, but even throughout the implementation phase of our rapid assessment process, is really knowing and engaging the assessment work that was already happening in those locations. Thank you for that question, Jennifer.
Thank you.
Any other questions or thoughts before we move on?
Samantha?
Yes.
Yeah, this is Dr. King at the Florida Public Health Institute.
Great. Thanks for joining.
Sure, but just to build on your comments, you were spot on. We were very fortunate here in Florida that as part of the accreditation process that has been a priority for our Secretary of Health and Surgeon General is that each of the health departments have completed a child chip. So that had already been done and almost completed for most of the counties in the state, in particular the 5 counties up in the Panhandle. And to your point, where we are working now is helping them to actually implement that, and what does that look like, and what kind of skills do they need to be able to implement that.
Great. Thank you again for chiming in there, Dr. King. So we'll go ahead.
And this is Jennifer. I'll just say quickly to Dr. King, we're looking for lots of information, and people are starting to talk about how do you actually do the implementation piece. So I'm sure we have a lot to learn from you there. So thanks for that.
Sure. Reach out to us anytime.
All right. So the next step in the process was around identifying the relevant data. Because of the rapid nature of the assessment process, we considered secondary data only. However, opportunities for primary data collection or gathering of existing data from local stakeholders were opportunities that emerged from our rapid assessment process, and we've continued to engage around those efforts around primary data collection, supporting their work around primary data collection, and also gathering of existing more local level data. So the assessment or quantitative data domains for the secondary data analyses were chosen from NACCHO's MAP core indicator list in order to facilitate the examination of determinants of health and health disparities in these communities. The list of domains and indicators were then shared with the GRHOP partners for their input, specifically around what would be important indicators to include in order to inform the community stakeholders and inform their conversations and decision-making around health priorities. These quantitative data were gathered from national data sources like the U.S. Census, American Community Survey, Behavioral Risk Factor Surveillance System, and local data sources as well, like state vital statistics and state hospital inpatient discharge data. So from the quantitative secondary data, we created a county health overview to present the secondary data findings for each of the counties. And we organized these overviews around three themes: who lives in the county, what influences the health of residents in that county, and what is the county's health status. These data were analyzed and visualized by LPHI staff in order to include in the county health overviews, and these overviews were distributed to the key informant stakeholders by county and also presented at the meeting where these stakeholders were gathered. So the next few slides, I just sort of show an example of the way in which we visualize the quantitative secondary data findings. So data on who lives in your county included data, demographic and socioeconomic characteristic data for county residents. So indicators such as race and age. Also, we looked at who lives in your county in terms of poverty, and we used mapping in order to represent that. And we were able to, this was one of the indicators that we were able to actually get data and represent at the sub-county level. So the representation here is poverty by census tract within the county. The next theme was around what influences the health of county residents, and this data included health resource availability and access, indicators of health resources availability and access, natural environment, occupational hazards and safety, social environment, mental health, and risk behaviors. So again, these are just some examples of how we visualize those data in the county health overviews as well as in the presentation to key stakeholders. And the third theme was around what is the health status of your county's residents. So these included indicators of mortality and morbidity, maternity and child health, and infectious disease. So our third step involved a guided prioritization process. And in figuring out what this prioritization process would look like, we were considering all kinds of processes to help us reach the stage of need prioritization. We needed to think about how stakeholders would consume the secondary data and have conversations around what they knew to be the health priorities, the health needs in their communities, and then determine what the health priorities were for those communities. So we grappled with questions like, what should this process look like? How much time do we actually need to develop this? And how much time do we need to devote to each component? How do you ensure that all votes are counted? So we ended up with a process that looked like this. Prior to the key stakeholder meetings, meeting participants were sent a pre-workbook that described the GRHOP and the Primary Care Capacity Project, their particular roles in the community prioritization process, as well as the guiding questions they would be discussing at this meeting. We also sent along with this pre-workbook the county health overview of the secondary quantitative data. Sending these two tools ahead of the meeting helped participants both prepare for the meeting and also help to create buy-in and transparency of the goals, objectives, and activities of this portion of the assessment. So I want to switch to show you an illustration of the actual workbook. So you can see some of the guiding questions we developed in order to facilitate the conversation, the focus group discussion around particular healthcare needs and barriers to care. and I have the actual tool. I think that the actual tools were distributed ahead of time. Sorry, you all, I'm trying to multitask and not doing a very good job of it to pull this up. So everyone should see a switch to on their screens. This first document is the actual county health overview we distributed prior to the meetings with community stakeholders in the 2 counties in Alabama. So this overview described our assessment process to start, and then it started to present the data that I laid out in step 2 of our process of identifying the relevant data. So this was the actual overview that was sent to participants prior to the meeting. The next document is the actual pre-workbook. And I'll pull that up now so you can see and get a little bit of a sense of the types of guiding questions we use to have discussions around what are the health needs, what are the community the assets and resources in the community, what are the barriers to care. So for example, on this first topic, we asked them to discuss and identify and discuss what are the physical health needs within your community. Does it affect a particular population? Is it everyone? Is it a target group? Is there a geographic scope to this particular physical health need? Is it across the entire county, or is it a specific community within the county? And then we also had asked them to talk a bit about potential interventions to address the need or issue. So this was sort of the process we engaged in when we had the stakeholders in the meeting, the day of the meeting. But they received this as well prior to the meeting again, so that they knew ahead of time what their role and what the process what the activities for the day of the meeting would be. Okay. So both we sent ahead of time the pre-workbook, and then the day of the actual meeting, they also received the workbook, which was the same as the pre-workbook. The next step of the prioritization process involved using audience response technology polling so that key informants could prioritize health needs from their list of 10 priorities from the facilitated discussion in real time by voting for their top 3 to 5 needs and barriers to care. And I'm actually going to back up a little bit because I forgot to share a piece of the actual meeting process. So during the meeting, key informants were split into breakout groups by county for a facilitated discussion on their community health needs, barriers to care, and as well as community resources, using the assessment workbook to guide the discussion. During that process, within their small groups or their breakout groups, they identify their top 10 health priorities for each of those groups. And then afterwards, the groups reported out on their top needs and barriers. And then our staff both combined and consolidated those top 10 needs across the different breakout groups in order to come up with a list of top 10. And from that top 10, that list of top 10 needs, they were able to use the audience response technology polling to vote in real time their top 3 or top 5 needs and barriers to care. So here, I wanted to point out here that the top 3 health needs and barriers to care that came out of all of our processes, really across Alabama, Mississippi, and Florida, were these 3 areas. They were around access to care, chronic conditions, and mental and behavioral health. and it's both the mental and behavioral health conditions as well as access to that care.
The conference has been unmuted. The conference has been muted.
Process that we engaged in, that we wanted to share. One important lesson that we learned was to utilize the people in the communities in question at all steps of the process. So I really appreciated Jennifer's question earlier about what was our process for getting to know what assessment work was already happening in these communities, who was doing that work, where they were in the process. And that was really an important lesson that we learned from the process at the end, but we were already sort of addressing that from the start, is using the people on the ground and in those local communities and the work that they're already doing in order to inform our processes and move our process forward. Another important lesson learned is that data can be political. We learned that the data that we show and also the data we don't show can cause political as well as emotional reaction. And comparing groups can be sensitive. One thing that we learned really from several presentations of data in this process across the 3 states was that the data didn't always represent what those stakeholders knew to be the reality on the ground for them. So again, that sort of goes back to that previous lesson learned about engaging those local community stakeholders at all steps of the process, including around the actual quantitative data as well. Another important lesson learned was around the pre-work. Sharing the county health overviews as well as the pre-workbook prior to the meeting was beneficial to creating buy-in. We heard from several stakeholders that participated in these meetings that they were happy to receive that ahead of time because they felt like they knew what meeting they were coming to. They knew the purpose of the meeting, what their role was supposed to be. So that pre-work really was helpful to create that buy-in and promote transparency. And another important lesson learned was to engage all partners engage them early and often. So there was a need to get all partners involved in both the creation of the process as well as the actual implementation of the assessment process. And then also following this assessment process. As I mentioned earlier, we embarked upon this rapid assessment process with a very specific goal in mind, and that was to really understand what are the health needs and priorities and barriers to care identified by the community stakeholders in order to inform our funding and resource investments in those communities with these GRHOP funds. But an additional important lesson learned was the continuation of the work that local health departments were doing, hospitals, the public health institutes in those states, around ongoing community health assessment and improvement planning work. So we didn't really have this particular charge going into our rapid assessment process, but we learned throughout that process a need for, and it was really an opportunity to continue to work with these local stakeholders around their ongoing assessment and improvement planning activities. So to that end, we did continue to work with these agencies and stakeholders around ongoing community health assessment and improvement planning work. So we've done that through technical assistance offerings through local and state health departments in all 3 of the states, also providing technical assistance and working alongside the public health institutes in Mississippi and Florida to deliver community health assessment and improvement planning technical assistance to their local health departments. And we also had a process where we provided facilitation and funding to a couple of the nonprofit hospitals in the Florida Panhandle to do community health needs assessments and develop and implement their community benefit plans. So I'm going to pause here and ask Dr. King if he could chime in at this point and talk a little bit about the work that both LPHI and Florida Public Health have done together with supporting the Florida County Health Department's accreditation work, and then really how Florida Public Health Institute is really continuing to drive that work forward. So I guess maybe Melissa,
the conference has been unmuted.
Everybody.
Great. Thank you, Samantha.
Thank you, Dr.
So we've embarked on this very fascinating journey with Dr. Francois and all the other our partners over at LPHI to try to figure out, since our county health departments have done the assessments and have developed plans, and which is now their next step of how to implement it and what does that take. So we've probably done, I would divide it up into a twofold set of skill development. One is around helping them with any kind of additional data analysis capacity. So we've done a webinar around leveraging and utilizing GIS, Geographic Information Systems, and data. We're probably going to do another one also for some of our partners that are interested in using the HRSA UDS Mapper, which is a similarly map GIS-based data system that allows folks to really drill down to look at specifics of communities from a number of different perspectives and parameters. And the other part of the work that we're just starting to get into is actually helping to do the skill development around engaging with communities around what activities they should implement. So I had the very special opportunity to go up to Okaloosa County and to speak with the health department, but this was an interesting meeting because it was the health department staff there, in addition to all of the daycare providers, or the leadership, I guess, of many of the daycare providers and Head Start programs in Okaloosa. And what they were trying to explore is trying to build this collaborative partnership with these stakeholders around implementing a program we call 5210, which is essentially a nutrition and sort of exercise way of trying to keep healthy. And it's been implemented in Sarasota County and a few others throughout the state. And I had a chance to go up there and talk to them specifically about what things to consider, how to form this collaboration, things to think about in terms of timeline, what are some of the challenges, what are some of your strengths, and how to be able to have a framework to help move forward on this specific activity or strategy that they want to implement. I'm probably going to be doing another session with the group in May, perhaps in June, and that will focus a little bit more on using a framework that I've used over the years called results-based accountability. And it's a framework essentially that brings, is used by leaders that are coming together toward a set of results. So it's an actual nice framework, and I've used it on and off over the past decade to help people implement specific or develop specific strategies, and dovetails nicely with the Community Health Improvement Plan. So we're going to be doing a session on that probably in May or June, with the idea that they use the plan, the CHIP, as a resource about where they may want to look to and invest in or focus on, and then using the results-based accountability framework and other skill sets to be able to pick certain results that they want to achieve, and then supporting them to be able to do that over the next year or two. So we're very excited about playing a role in helping them move toward implementation, and this is an area of work within FPHI that we're rapidly growing throughout the state. And I'm sure many of you had the experience where there are groups that come together and develop wonderful plans, but then there either is a stall or a delay or something happens that prevents them from moving from the plan to actually taking action. And so we're trying to really form the nidus of resources and expertise and skill development to help people to move from just a plan to actually taking action around a specific set of results for their county or for their community. So we're very excited about this opportunity, and again, we could not have done this without the support of our colleagues at LPHI. And we are looking forward to sharing with you all some of the progress that we're doing in that area and keeping you abreast of what turns out. And if you're interested, feel free to let us know. You can get in touch with Samantha or myself or any of our staff, and we'd love to share with you what progress we've made with some of the counties up in the Panhandle.
Thank you so much for that, Dr. King.
Sure.
And I am at the end of my presentation, but I did include at the end links to resources that I'm pretty sure most, if not all, on the call are familiar with. These were really the resources we use to inform our rapid assessment process, to inform and adapt our process. And, we sort of joked along the way that we were sort of making it up as we go along. And it kind of felt like that sometimes, but we really did use, standardized approaches and models that were out there and did adapting to fit the specific situation we found ourselves in needing to go into these communities that were not our own, and we needed to understand what was going on in those communities in a very short time frame. So I did provide these links at the end of the slides. And then also, as Dr. King mentioned earlier, feel free to contact us beyond today if you have any questions, comments, or insight into these processes moving forward, and we can open it up for questions and discussion. There was a question that came through on the chat about what was the name of the GIS mapping system, and I answered it. It was UDS Mapper, and that is correct, Dr. King, right?
Yes, that is it. I think there was some discussion, I don't know if Mike's on the line, about a uniform GIS system that the 4 counties wanted to agree to, and I'm blanking on the name of it. It might have been ARC, but
okay.
I'll confirm that.
Any other questions, thoughts? Well, all of the tools that I made reference to in the presentation, I believe, have been made available to everyone who registered. And Melissa, correct me on that if I'm wrong. And once folks, once you look at these tools, again, if you have any questions about them, again, don't hesitate to contact me. I'm happy to answer questions or talk through them with you all.
Yep, that's correct, Samantha. I posted the link in the chat box a little bit earlier on, so if anyone wants to access those tools, they can just click on that link. Well, it sounds like we don't have any questions at the moment, at least. So I'll go ahead and wrap us up. I'll add right now a link to the chat box for a quick evaluation. So please take a minute to fill it out and provide your feedback and ideas for future topics so that we can improve the series going forward. The next webinar will be Wednesday, June 4th at the same time, 3 p.m. Central. So stay tuned for more information about that. We'll be sending out the presenter name and the topic via the NNPHI Top 5 and the Community Health Improvement Work Group list. So stay tuned for that. And finally, just a huge thanks to Dr. Samantha Francois and Dr. Roderick King for sharing their experience today and all these great tools. And a big thank you to all of you who participated as well. Thanks, everyone.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Bye, everyone. Melissa? You still on? Hello, Melissa?
Well, thank you for helping. No one sent any questions in, so there are technical issues. No.
This conference will now be disconnected. Goodbye.